Afternoon, everybody. It's lovely to see you all again today. I am really excited to introduce Lisa to join us for our October support obsession for our quality management stream. So Lisa has been working with us on the Quality Specialty Advisory Panel for a little while now, and her career history is on the screen in front of you. You've had a exciting and varied career, Lisa. I like the look of this, and fab, because as a fellow microbiologist, I'd love to do my PhD, but there you go. So I'm a little bit jealous as well. Lisa knows everything there is to know about 17025 and 15189, but today's session we're just going to talk about continual improvement and tools for how you can manage improvement within our pathology discipline. So something that is absolutely core to everything that we do every day within pathology. So with no further ado, Lisa, I will stop sharing and you can share your screen and then we'll get started. Perfect.
Okay, thank you very much, Deborah, for the kind introduction there. Can everyone just see my slides? I can't actually see any of you.
Yes,
that's great.
absolutely.
Thank you. So today I'm going to be talking about tools that we can use for quality improvement projects within our pathology services. And really what I thought I would kick off the session by asking is, what's the difference between change or quality improvement? Is there any difference? Well, there are subtle differences, and change refers to an alteration in a process, a workflow. It could be a piece of equipment or how we do things. Change can have a positive impact, it can have a negative impact or no impact at all. And examples can include, switching to a new staining reagent, perhaps introducing a new digital pathology system, or reorganizing specimen reception workflow. So all those changes could be positive, they could have no impact at all. So if that's change, what's quality improvement? Well, quality improvement is a structured, systematic approach taken to make processes better, safer, and more efficient. And typically, quality improvement is intentional, and it focuses on measurable benefits for patients, clinicians, and the laboratory team as a whole. So examples could include reducing turnaround time for issuing reports by addressing bottlenecks. It could be standardizing specimen labeling protocols to reduce misidentification, or it could be setting up critical value notification so that clinicians receive automatic alerts for urgent results. So to summarize, change is simply doing something differently without guarantee of improvement, but quality improvement is a deliberate, evidence-based approach that is measured and sustained to enhance quality and patient safety. So all improvements are changes, but not all changes are improvements, according to Eli Goldratt. So what does ISO 15189 have to say about quality improvement? Well, in the similar vein to risk management, there's a theme of quality improvement throughout the standard, but there are two clauses in particular that I would draw your attention to, and those are 8.5 and 8.6. Actions to address risk and opportunities for improvement, and 8.6 is improvement. So basically, labs must continually improve the effectiveness of their quality management system. They need to be actively looking at the pre-exam, the examination and post-examination phases to identify areas for improvement. These would need to be documented and action plans implemented. And as with all things, priority assigned to those activities with the highest risk. After the improvement action is implemented, we need to ensure that we monitor the effectiveness to confirm that it has had a positive impact. So you might ask, where do I get these quality improvement activities? Well, there are a number of areas that you can seek quality improvement activities, and this list is not exhaustive. You can look at internal audit, get feedback from your users, also get feedback from your staff. Look at your EQA results. Are there results that are starting to drift or shift? Might you be getting a poor performance notification in the near future? Management reviews are also a good source of quality improvement activities because you have a wide range of people in the room. You'll have clinical staff and laboratory staff. So it's really good to get ideas coming out of those management reviews. You can also seek opportunities for improvement in your corrective actions. But I think within the pathology services, getting information from your staff is key. Staff suggestions are really invaluable for quality improvement activities. And as managers within pathology services, we need to be fostering an environment where staff feel that they can bring forth their ideas and that those ideas will be listened to. So communication is really key, and getting all the staff within the department involved. There are a number of different stages in quality improvement projects. For example, you first of all need to identify the problem, the area for improvement. You need to look at your current processes and analyse them. In pathology labs, certain areas maybe have been operating the same procedures for a long period of time, and maybe it's the same key staff who are working in those areas. And we need to look at all areas to see if we can improve things and map out our processes. It's also important to define the goal or the scope of your project. Whenever you have a large number of people involved in these projects, there's the tendency to build on what you've already started, and maybe the scope can begin to creep. But it's important that you really define that, because the last thing you want to do is make the project too big, and then the timelines are really affected, and then you get a non-conformance. You need to develop an improvement plan, who's going to do what, how you're going to do it, when you're going to do it, and implement the change in perhaps in a pilot form, and we'll talk a wee bit about that later. We need to monitor and measure outcomes. You need to have a baseline of how things stand before you do the improvement action, and then monitor the process in order to evaluate the effectiveness of the action that you've put in. Like all things within pathology services, not everything works first time round. So it's really important that what you learn as part of these projects is shared amongst the team, so that you can learn from experience and not make the same mistakes twice. But thankfully, there are a number of different tools, quality improvement tools, that can be used to help us in the process. And basically, quality improvement tools are methods and techniques used to identify the problem, analyse processes, and implement solutions with the overall aim of improving efficiencies, effectiveness, and outcomes. And the benefits of using these tools are that they offer a systematic approach to problem solving, and they allow data-driven decisions. They help us collect and analyse data to inform decision making, and offer an environment for continuous improvement. So tools support a culture of ongoing improvement by tracking progress and identifying areas for enhancement. And it also involves team collaboration, so that you're fostering an environment of shared understanding and taking into perspective the views of others. I'm going to talk about 6 tools today, and this list these are not the only tools that can be used, but they'll give you a flavour of what can be used and how you can implement them within your laboratories. So the first one is process mapping or flow charts. And I think it's really important that we look at our processes. As I mentioned before, some areas have been working using the same SOPs, using the same laboratory for a number of years. And it's important that we walk with the sample through the laboratory. Some labs have a clinic associated with them, and you can map the patient journey and track the sample going through the lab. And this helps us identify bottlenecks. It helps to look at error-prone steps and any redundancies in the system. So in this example, anything that has a negative impact on the patient is denoted by a sad face. The next tool I'm going to talk about is the use of check sheets. And this looks rather simplistic, but this information feeds into other statistical methods that can be used. So check sheets require no equipment apart from a pen or pencil and some paper, and they allow the staff doing the work to collect the data. And they provide a way of capturing data readily over time, recording the frequency of errors or issues, and you can add or remove from the list as you go. So really, you can put these in specimen reception to track specimen reception errors, maybe give them on through the week and the weekend to see if there's any difference over the weekends. And it's really, really easy to collate this data, and then it can be put into the likes of Excel to form graphs. And it can be used, as is shown in the next example, to create a Pareto chart. Now, according to the Pareto principle, which is also known as the 80-20 rule, in any group of factors that are contributing to an overall effect, in this case, sample rejection causes, roughly 80% of the effect comes from 20% of the causes. So a Pareto chart is a type of chart, it's a bar chart, which the various factors that contribute to the overall effect are arranged in order from the largest to the smallest contribution. So in this example, the highest frequency of errors is mislabeling and the lowest is leaking sample. And this ordering helps identify the vital few, and those are the factors that have the largest contribution to the effect and therefore warrant the most attention. As distinguished from the useful many, those are the factors that, while they're useful to know about, have a relatively smaller contribution to the effect. And using a Pareto chart helps teams concentrate their improvement efforts on the factors that have the greatest impact. It also helps teams explain the rationale for focusing on certain areas and not others. So in this example, how do we actually read the chart? Well, the bars in orange show how often each error occurred. The red line shows the cumulative percentage of errors as categories are added from left to right. And the 80% reference line highlights the point where the majority of errors are explained by only a few categories. So in this example, the 80% line cuts across here and shows that mislabeling and incomplete forms are contributing greatest to the overall effect. So this helps labs prioritize which issues they should address first. The next tool that I'm going to talk about is the fishbone diagram, or the cause and effect diagram. It's also known as the Ishikawa, named after its creator. And this is an organizational tool that helps teams explore and also display the many causes contributing to a certain effect or outcome. It graphically displays the relationship of the causes to the effect and to each other, helping teams identify areas for improvement. So teams, what they would essentially do is list causes under the categories of materials, methods, equipment, environment, and people. But in this case, they have chosen to do specimen, personnel, reagents, lab environment, test system, and post-analytical activities. So you can choose the most likely causes to be contributing to the effect. And what this system allows you to do is it allows the team to focus on the content of the problem rather than its history or the differing interests of team members. It focuses the team on the root cause and not the symptoms. So the problem is stated at the head of the fish, and the causes are grouped into major categories. And for each category, the team would come together and carry out brainstorming to list all possible causes as sub-branches or ribs off the main bones. And the group analysed the diagram to understand the most significant root causes that need addressing. And once that root cause has been identified, a targeted solution can be implemented. One of the real strong benefits of using this approach it's a collaborative approach to problem solving, and it focuses on root cause rather than the symptoms. Now, a number of labs will be using statistical process charts, perhaps for monitoring internal quality control, third-party control. But statistical process control charts can be used to monitor quality improvement activities. So really, an SPC chart is a graph charting data over time. It's a simple and effective tool to depict the current performance of a process and to help you to determine whether the changes you're making are leading to an improvement. So before improvement initiatives, SPC charts can establish a baseline of current processes in terms of capability and variation. And after changes are made, the same charts can confirm whether improvements are sustained and statistically significant. When a process change is implemented, SPC charts show whether the variation or average has improved and if improvement is stable over time. So this helps to distinguish between short-term success and long-term control. So the SPC charts are showing trends, they're showing variation and the effects of intervention. In the example above, the blue dashed line is the average defect rate before improvement, and the red hashed lines are the upper and lower control limits, which depict natural variation. The vertical green dotted line marks when a process was implemented, and after that point, the defect rate drops and stabilizes below the previous average. So it's a clear visual sign of sustained improvement. So whenever you get to this stage after improvement, you would be wanting to recalculate the mean and applying new upper and lower limits. The last tool I'm going to talk about is the Plan, Do, Study, Act. And this is a cyclical approach to implementation. And the PDSA cycles test changes to assess their impact, ensuring that new ideas improve quality before implementation on a wider scale. Making changes to processes can give unexpected results, so it's safer and more efficient to test quality improvements on a small scale before whole-scale implementation. And this allows a sample of stakeholders to assess the proposed changes in action. So small-scale change introduction also enables interactions with other systems to be tested without causing large-scale disruption to service quality. So for example, if you're making a change that would involve limbs, you don't want to be implementing a major change in case it problems the whole system. So PDSA cycles allow ideas to be introduced in a safe, controlled way, which will have less resistance, be less disruptive, and use less resources. And by building on the learning from each cycle, new processes can be introduced with a greater chance of success. So what are the different phases of this cycling? So in the plan phase, you need to define the objectives. Again, state the scope of what you're planning to do, what, why, who, how, and when is going to do it, how long you intend the cycles to continue. And here, a key one that you should consider is also, are there any circumstances when you would stop the trial and go back to the drawing board and replan things? It's also important in these projects to determine if everyone understands their role and the part they have to play in the project. In the do phase, this is implementing the phase, and it's important that we encourage continual feedback so that we can gauge whether the project is going to be a success and have the positive impact that we hope. We need to motivate, reassure, and encourage the staff who are doing the testing. And it's important in this phase too that we gather the information to determine whether the change or the improvement has been in fact an improvement. In the study phase, this phase really involves reviewing your findings, comparing the data from before you made the change, during the change, and after the trial. And it's really important to reflect on what was learned. Was there any information received from staff or patients regarding an improvement? Did the process take longer, or did it take place in the time frame that you expected? Did you achieve your objective? If not, why not? What went well and what could be improved? In the act phase, you need to use the information that you have gained. Do you need to modify or retest? Do you have enough information? Do you need to trial the cycles for longer? And can you implement the change immediately? Finally, I'd just like to say that the key to successful improvement projects are collaborative effort. You need to make sure that you have the right people involved. You need to be involving the staff who are testing the samples, reporting the samples, the clinical teams. So getting their input is really invaluable in all these processes. There needs to be effective communication amongst the team. And the data, the project needs to be data driven. You need to have smart targets. They need to be specific, measurable, achievable, relevant and time bound. And we need to culture an environment of learning within our departments so that we have a continuous quality improvement cycle where we're developing, we're implementing and we're evaluating. John Ruskin said, quality is never an accident. It is always the result of intelligent effort. That has been a whistle-stop tour of some quality improvement activities that and tools that you can use within the laboratory. There's lots of information available on NHS England, and I can share some of that information with you if you would like. I'm going to stop sharing now. Hopefully
Thank you so much, Lisa. That was really, really informative and fab for the audience to hear. There are so many quality improvement tools out there, and to have a broad overview of some of them is fab for people to go away, dive a bit deeper, explore some of the ones, because I think we all fall into a habit of using some of the same ones repeatedly. You know, we do PDCA all of the time in some circumstances, but they maybe haven't tried fishbone before. So using some of the different tools is also really important to think differently about how we can do some stuff. So thank you ever so much. The audience is very quiet this afternoon. We haven't got very many questions in the chat. I will just say in answer to the one, we will share Lisa's slide deck, and the recording will both be made available on the IBMS website, and I've put the link in the chat for you, and you can go back and look at all of our previous quality hubs and all of the other webinars that the Institute provide. But I do have a couple of questions. Oh, Mel's put something in now. She's keen to know how teams share these outputs of quality improvements other than on QPulse, because it's really important that we share and celebrate, Lisa, isn't it? So how do you go about doing that?
I think it's really important at interdepartmental meetings to be sharing knowledge, and especially what goes well and what doesn't go well. There's no point in reinventing the wheel every time you start one of these projects. So interdepartmental meetings, it could be quality groups, you know, where all your quality teams are together discussing. That's what we do in Belfast. We have a quality operational group, and we would discuss these things as well as putting them on QPulse.
I'm going to make a blatant plug for things like IBMS Congress as well. There are always opportunities for posters to shout about the work that you're doing, to celebrate it. It's a great way of being able to attend national or international conferences by doing a poster, and it's a great way of ensuring the team get that recognition that they so rightly deserve. So yeah, lots of different ways of doing it, but just remember to celebrate the good work of the team. I was going to pick up on something else we talked about in that, and sometimes these don't go quite to plan, do they? And sometimes we don't get the results we want, and we would consider that failure. I am of the strong opinion that failure is probably the best breeding ground for learning, for changing, for making things a little bit different. Lisa, I don't know whether you've got any experience of that.
Yes, we've had ones that we thought were going to be brilliant, and we started tracking the data and we were barking up the wrong tree. So I think it's really important that you are capturing relevant data and also be bold enough to say, you know what, we've got it wrong, we need to go back to the drawing board, because that is much better than trying to implement something and moving a project down the line too far that you almost feel you can't go back. But you need to be bold and say, no, this is not working. We need to go back to the drawing board and rethink how we're going to do this, and use the data that we have to infer the decisions we make. And I think the Pareto charts are really good for that. You know, before we were just looking at the bars and we weren't really considering what was going to have the most impact. So it's using the data that you have and more effectively and mining that data.
Fab. You can always rely on Nigel for a tricky question. So I have done a bit of prep in the background because this is also one of my favourites that we get asked quite a lot. ISO talks about continual improvement rather than continuous. Is there a difference? So for me, and the kind of definition that I always go back to, so I've pulled up a paper in the background, continuous improvement is uninterrupted change. It's theoretically ideal, but it's unrealistic. Continual improvement is iterative and sustained progress. So it's realistic and achievable. And that's why ISO use continual rather than continuous. I hope that helps. The last question really from me is also around how do we manage change, especially within the NHS, where we just seem to be in permanent change cycles. So our teams are now starting to suffer with a little bit of change fatigue. So how do we keep them with us, engaged, empowered? Any tips, Lisa?
I think, you know, you can, as you say, you can get fatigue. And I think you need to have smaller working groups, you know, so that it's not the same people all the time, and using the whole team and delegating activities. That by delegating activities throughout the team, you're empowering all the staff. And I think that's where you get more buy-in for change and less resistance to change. But yes, there is a lot of change happening within pathology services, but I think breaking it down into smaller teams and giving more people a role to play helps.
Absolutely. Thank you ever so much. Yes, I'm more than happy to share those definitions. Someone very clever within the world of ISO once shared them with me, and I've hung on to them since then, Gary. So yeah, I'll absolutely put those in the chat second for you. I'm sure we will all take the opportunity to say a huge thank you to Lisa this afternoon. That's been a fabulous presentation. And thank you for introducing us to some of those tools, and hope we broaden our skill in trying some of them a little bit differently. Nigel, I'll come to you in 2 seconds if I can work out how to get you off mute. The next couple of Support Hub series coming up. So in November, we will look at artificial intelligence and its role in transforming diagnostics. It's really important, but it also introduces a whole new series of challenge in how we manage that safely and under a quality controlled environment. And I can't bring myself to write the C word under the December meeting, but we're looking at doing a quiz. Still learning, still educational, still informative, potentially prizes to be won too. So please think about joining us in December as well, when everybody's starting to just get a little bit jaded as we head to the Christmas season. But anyway, thank you ever so much for joining us this afternoon. It's been fabulous to see you all. Please share the link to the website with colleagues and friends. There's some brilliant resources there. But in the meantime, thanks, Lisa.